Hi everyone and welcome. We'll just give people a few minutes to get onto the platform and then we'll get started. So welcome. I'm going to give people 30 more seconds to join and then we'll start with some housekeeping notes before we get started. Okay, it looks like we have a good amount of people, so we'll go ahead and get started. Good morning, good afternoon, good evening, everyone, and thank you for joining for the first set of NNN workshops. Before we get started, I'm just going to read off a few housekeeping notes. So you'll notice that you entered the workshop with your cameras off and your audio muted. If you could please keep your audio muted to help keep background noise to a minimum. If you are invited to speak, please unmute yourself by pressing the microphone button in the bottom left-hand corner, and feel free to switch on your video again by using the button in the left-hand corner. During this session, we'll be doing some room and breakout groups. When it is time, you will automatically be moved into a breakout group by one of the MIT team, and no action is required from yourself. Once you're in the breakout room, please turn on your video using the button in the left-hand corner. You may also mute yourself when you wish to speak and participate. Again, please mute yourself after you've spoken to avoid any background noise. Once the group work is completed, you will automatically return to the main room after a 60-second warning. Please do take note of your facilitator's name when you move into the breakout room. Should you become disconnected at any point, we can use this information in order to add you into the correct breakout group. We ask that you switch your video on when you video off and audio off when you return to the main room. If you wish to interact during this session, please use the chat facility on the virtual meeting platform as we did during the plenary. And you can do this by going to the agenda tab in the virtual platform and clicking on the session, which you should have already accessed to reach this workshop. Hopefully you all have seen the mail sent out on Monday detailing how to communicate during the workshop with the chat facility. If you are operating on one screen, you can view both the chat and the presentation. Please email the MIT team at admin@nnnevents.com if you're having difficulties using the chat facility, and they will be able to help you. Finally, the MIT team are here to help you with any technical difficulties. Again, please email them at admin@nnnevents.com, where the MIT team will reply to you immediately. That's all we have for the housekeeping. I am going to get us started. I'm just going to share my screen so that I can get the sound. Just give me 1 minute, please. So we're going to get started with a little video explaining the work we've done on the COVID response, and then we'll jump into the session. So please enjoy.
My name is Joyce Sherman, Assistant Minister for Preventive Services. At the Ministry of Health in Liberia.
Okay, it's into the PowerPoint, so it should.
West Africa. The 3-year ASCEND West and Central Africa program, funded by UK Aid, will protect millions of people by making major progress towards the control and elimination of 5 painful neglected tropical diseases, NTDs, in 13 countries. However, in response to COVID-19 pandemic, the program worked with partners, program country governments, and communities, taking advantage of our collective expertise and capacity to help program countries respond. Thank you and have a very fruitful meeting.
Within a 10-day period, we submitted 11 country proposals, flexing our funds in response to COVID-19, when the Department for International Development approved 10 of those proposals during a Zoom call. I think I went into shock at the magnitude of the task ahead of us. But prior to this, the first step was to engage with the Ministries of Health to develop the proposals. Pelagie, what was your experience of engaging with ministries and partners so quickly at Benin?
As we were partners with the Ministry of Health prior to the COVID-19 pandemic, we were able to base on that existing relationship. We are members of the response team, and that has made working together much easier. In addition to working with the ministries, we also had to work alongside the government-led task forces. Umar, how was your experience in creating this relationship?
In Guinea, the task force is part of National Health Security Agency. In the absence of face-to-face meeting, we found a great way to continue building the partnership is kept up communication through email, phone calls, and WhatsApp messages. We've also worked with community volunteers to carry out of the work in the communities. David, how did you work with community volunteers in Ghana?
We have trained 600 health workers and 200 teachers in infection prevention and control, disease surveillance, and risk communication. I think one of the best things we have achieved out of all this is the new relationship we have created, which have the potential to help the NTD work we are doing. Once it is safe to start the NTD activities, we will explore the opportunity of building on these new relationships to facilitate NTD activities. Leah, what lessons do you think we can take from COVID-19 response to NTD?
Thanks, David. That's a great question. I think the types of communications we produce and the lessons we can learn from the creative process are very beneficial. For example, it's important that we keep messages simple, single-minded, and emotionally engaging.
At MSc Saatchi, the COVID work revealed the range of challenges and complexities we should be aware of with the NTD activity. For example, that there is a lot of misinformation and mistrust of health advice. This is a huge learning when developing any communication around drug administration. It's also highlighted the importance of tailoring activity to cultural context, as well as selecting the right messages to deliver them in different communities. While reflecting on all that we have accomplished, I can't help but remember how much effort went into responding so quickly. I wonder what kept people up at night.
I will go first. All the details and many processes involved in producing culturally appropriate messaging in such a short time frame kept me up late into the evening.
For me, it's worrying about those who ignore the guidance and risk exposing themselves, their family, and community to COVID-19. As stressful as it was, it really brought us close together.
It was the commitment and determination of colleagues which has enabled us to rise to this challenge. What an incredible team effort. Thank you so much to everyone involved.
My name is Joyce Sherman.
And now over to you, Jordan.
Great. Good morning, good afternoon, good evening, everybody. It's nice to see all these names. It looks like we have a full house. And so I just wanted to quickly introduce the group of people that's going to be speaking today. So we're going to have Heather Burgess, who's the project delivery coordinator of the Ascend West program, working for Sightsavers. We also have Leah, who opened the session, and Leah Wohlgemuth is the global technical advisor on WASH and behavior change for NTDs with Sightsavers. We also have with us Andy Wright, who's the head of strategy and social impact practice at MNC Saatchi World Services. We also have David Ajaman, who is the senior program manager for Sightsavers in our Ghana country office, as well as Dr. Joy Shaibu, who is the director of operations in Nigeria for Sightsavers, as well as Becks Hill, who is one of the project directors at Sightsavers and the team lead for the program optimization unit under the Ascend West program. And of course, myself, Jordy Woods, I'm the director for behavior change and WASH programs at Sightsavers. And I think next what we'd like to do is get a little better sense of all of the people that are with us, at least virtually. And we would like to do a quick Slido poll with everybody. So if you could navigate to either your browser or your telephone and go to sly.do and enter the code NNN, we will ask a few questions just to get to know each other and kind of find out what everybody else's experience in this room has been with COVID-19. It's certainly been an adventure over the last 6 months, to say the least. So I believe, Leah, are you able to share your screen? There it is. So the first question for those that are still getting on there is, we'd just like to kind of get a quick sense of where folks are calling in from, and it'll kind of come up and we'll give it another 30 or 45 seconds to see who's with us. I think we have Brighton, USA, and Nigeria in the lead so far. I'm going to give it another maybe 15 seconds. Awesome. Wow, we have a lot of folks from different places. So it's early morning here in New Orleans and probably late night for those that are in Australia. Let's move on to the next question, Leah. So just also to get a sense of what everybody in this meeting does, you'll see questions about what your area of work is, whether you're at an NGO headquarter, a donor, maybe you work for a government, Ministry of Health or another ministry, research or academic institution, the WHO, or other. So as this is the NNN, it would make a lot of sense that a lot of participants work for an NGO. Awesome. Okay. Great. Well, let's move on to the next question. Just to sort of, as this session is really about the COVID-19 response, the question is, have you worked directly on the COVID-19 response in your own work in the last 6 months? And it's hard not to have been affected or at least done something. So yeah, I would say a good portion of this group so far, I certainly have worked within the COVID response. Okay. Let's move on to the next one. The last question is, so if you were one of the yeses, what have you done? Have you been part of a task force? Have you directly been implementing COVID-19 programs? Have you been working on resuming NTD activities in the face of COVID-19? Perhaps COVID-19 outreach activities, working in a lab? And I know that a good portion of, I'm sure, a lot of the conversations in today and the next couple of days will be about resuming NTD activities within the COVID-19. You see a good number on doing research, directly implementing. Interesting. Great. Well, thanks. I think that this helps certainly us as presenters and everybody else in the room to kind of understand where we're coming from. So this was the slide to happen before we went. So now we know you a little bit. And before I hand over to Becks, just a quick overview of what we're going to be talking about today is Becks Hill will give us sort of a brief overview of what the COVID response for West Central Africa was under Ascend. And then we're going to have Andy talk us through what MNC World Services has been doing with us in this response. And then we'll have two excellent examples from some of the work in both Ghana and Nigeria, followed by some breakout rooms, and you'll be assigned to 4 different breakout rooms to talk about how this group has worked within COVID-19 and some of the insights that we've gained, and then we'll come back. So just quickly before I hand back over, we really want to kind of understand, provide an overview of how the Ascend West program responded to COVID-19, and just give a couple of examples of really what that process was in terms of how the creative process went within mass media campaigns, and then show the real examples, sort of the outputs of that. And as I mentioned before, to reflect on the insights from how we can take this work and build it into our NTD program. So with that, I'm going to hand over to Ms. Becks Hill to give us the overview of the Ascend program. Thank you very much.
Thanks, Geordie, and hello everyone. A very warm welcome to you all, and thanks for joining us. I don't have much time today, but the speed at which I'm about to speak gives you a feel of the pace of our work these last few months, which echoes Mwele's opening words, that we're in a world where we have to achieve more for less. So, as a bit of background, the Ascend West and Central Africa programme is FCDO's, formerly DFID's, largest investment in NTDs. It's a game-changing integrated NTD programme. We're working as a consortium, Sightsavers, STIF Foundation, LSTM and Mott MacDonald, working across 13 countries with a focus on 5 NTDs. Working in partnership with ministries, communities and partners, our key areas of work are health system strengthening, behaviour change communication, leave no one behind, and support in areas of watch. We support surgeries for trachoma and hydrocele, training of case finders, and we manage a learning and innovation fund. We also support MDA, and in 3 years, we aim to deliver over 300 million treatments across the countries where we work. When COVID arrived and monumentally impacted all of our lives, we worked with FCDO to look at feasible options to flex our funds in response to the pandemic. This is a quick timeline of our journey in terms of repurposing our efforts and flexing our funds in response to the pandemic. During March, we made flexing suggestions to FCDO in relation to areas of work where we could potentially provide meaningful support. By the end of March, we were given the green light to flex our funds. In April, we worked with ministries, COVID task forces, partners to identify and define gaps and to develop 11 country proposals, requiring a huge collaborative and consultative effort. In May, we were waiting for approvals and were busy adapting our processes and procedures in order to ensure the right systems were in place for our potential country responses. All 11 were approved in May and in June. In May and June, on approval of the proposals, there was a huge amount of backwards and forwards with ministries on finalising scopes of work. And then in June, we began implementation and we aim to complete our COVID responses by November. Next slide, please. So in summary, we're providing 11 country COVID responses, and in 9 of these countries, we have direct support from our behaviour change communication partner, NNN Conference. And we have and are continuing to roll out mass media campaigns, which have included TV and radio spots, social and digital ads, influencer videos, billboards, training guides, banners, flyers, posters, and leaflets. In some countries, we're supporting contact tracing, training of community volunteers, training of health workers and teachers, and in health facilities. We've also been providing some sanitary items in some of our countries. Next slide, please. So here are just some of our highlights today. In June, we conducted focus group discussions in all 12 departments in Benin. In Ghana to date, we've now trained over 750 health workers and 200 teachers. In Sierra Leone, we trained 2,400 CDDs in 8 districts. Overall, we've developed a total of 9 behaviour change campaign country strategies, which will have a phenomenal reach of over 100 million people. Next slide, please, Leah. So you'll hear more about country-specific lessons shortly, and this isn't an exhaustive list. There are many, many more, but here's just a few top liners. Number 1, we were able to shift from business as usual to that of an emergency response, working as a consortium to reach consensus and shift our focus from normal NTD work to put together appropriate and feasible responses to a global pandemic. Number 2, we have found that there are huge lessons to be learned working alongside NNN Conference and how involved the creative development process is for effective mass media campaigning, and how we as an NTD community need to look beyond flyers and posters if we're looking to reach people impactfully and at scale. We've so much to learn from these experts, and we hope that this BCC legacy can have a long-lasting impact on how we approach BCC for our NTD activities as we go forward. Number 3, collective action was the only approach that could be taken to address a public health crisis of this scale. We had to expand beyond our normal NTD program contacts, and in so doing, we hope that we've developed lasting relationships which will improve our collective action in combating NTDs as we start to resume activities. What COVID offers is the opportunity for us to change, an opportunity for us to reframe our approach to NTDs. We have opened doors and we can improve our impact as we resume activities. This has to be one of our key lessons and a positive outcome of our responses. Thank you very much for listening. I would now like to warmly welcome Andy Wright from NNN Conference.
Hi everybody, I'm Andy Wright. I'm the Head of Strategy at NNN Conference World Services. For anyone who maybe isn't familiar with the organisation, NNN Conference is a very successful, world-renowned commercial sector communication specialist, and then within that, World Services are, as Becks touched on there, behaviour change specialists, particularly in the development sector. So what NNN Conference World Services offers is the combination of those two things: best practice from the commercial sector and effective communications combined with development sector knowledge, understanding and partnerships. So till now we have been the communications and BCC specialists for the Ascend programme, working on prevention of NTDs, communications to prevent NTDs. And like I'm sure many people on this call, our work has had to adapt to COVID in the last 6 months or so, with the NTD programme temporarily on pause while we focus on that. Go to the next slide. The behaviour change in question has related to COVID behaviours. I'm sure everyone on the call will be familiar with these because, as these images show, the behaviours are the same all over the world. I've got images here from North America, Russia, parts of Africa, and it essentially tends, France, it tends to boil down to the same 3 things, which is prevention behaviours, symptom recognition and symptom response, and they're essentially the same all over the world. The thing that varies in our case, if you go to the next page, is the context, because while the behaviors might be the same and the virus might be the same, the context in which we're trying to achieve those behaviors are different, and that means that the communications needs to be different too. So we work across these 9 countries within the 11 countries that Becks outlined before. And then I guess it's worth explaining that our role is communications, but we aren't the lead communicators. Obviously, in any given country, generally speaking, the government leads communication and advises the masses. They do things like daily press briefings. They tell people if the risk is going up or down and if there are new behaviors that they need to adopt. So our role isn't to lead. Our role, if you go to the next page, is reaching those who are hardest to reach. And obviously people can be hard to reach for different reasons. It can be because they are geographically remote. It can be because their literacy levels are lower. It can be because they are vulnerable in some way. So yeah, our role is to support those lead communications that happen at a government level with specialist communication for those who are hardest to reach. So then I was asked to talk a little bit about what our principles are for communication in general, and then also how we've applied those to COVID communication. So I guess an important thing to say is that something that rarely works, but something that is often done, is people take loads and loads of behaviors, try and pack them all into a single execution and kind of say to people, do all these things. And while that might seem like a good approach, we know, particularly from our kind of commercial sector knowledge, that kind of approach communication rarely works because it really gets through. So talk a little bit about why it doesn't work, and then 3 good principles we think for more effective communication. So the first is simplicity. So this data is from a company called Millward Brown, who are basically the world leaders in measuring communication in market. And their database shows that the more messages you put into a piece of communication, the fewer things people take from that communication, which obviously sometimes is counterintuitive to what we think. We think, why don't we just tell people everything we want them to know, and then we can be very effective with a single execution. But that isn't obviously what it achieves. The more things you say, the less things people retain in their memories. So the strong advice here is keep the messages to as much of a minimum as you can, 1, possibly 2, 3 at a stretch, never 4, never more than that. So simplicity is the first principle. The second is emotion. So this data is from the IPA, which is the Institute of Practitioners in Advertising. It's essentially the best effectiveness database on communications campaigns. And what it shows is that across the board, campaigns that are emotional are more effective than campaigns that are rational, which isn't to say there shouldn't be a rational element to your communication, but it strongly suggests that there should be a compelling emotional component. Emotional campaigns are more effective at what commercial sector businesses would refer to as hard measures like sales and pricing, but also softer measures, things like quality perceptions or trust perceptions. Across the board, emotion is very powerful at creating stronger effects and longer lasting effects. And then the third thing to mention is motivation, which is that when you want somebody to do something, not all the time, but a lot of the time, telling them why they should do it is more motivating than telling them what they should do. So what we always try to do when we arrive at a new task like this one, why aren't people adopting the behaviors that they're being asked to adopt when it comes to COVID prevention and spread? We do research on the ground to understand the barriers why people aren't acting in the way that we might like them to. So in this instance, our research, if you go to the next page, our research across the countries in question showed that there were sort of problems behind the problem. For instance, there's a lot of stigma, particularly in countries that had problems with Ebola, that people don't want to be ostracized and don't want to be seen as having symptoms, which leads people to potentially hide symptoms and not respond to them, a belief that they won't recover in the same way that far more people didn't recover from Ebola. Very widespread problems of misinformation, particularly in the WhatsApp age, where lots of people potentially thinking that they're being helpful are spreading information that's been put out there, who knows who by, that simply isn't true and isn't good advice. Quite widespread issues of complacency. We've heard from all the different regions this idea that COVID is potentially a white man's disease that doesn't affect people in Africa. Also potentially younger audiences thinking that it doesn't affect them, so they have nothing to worry about, potentially oblivious to the impact it can have on others. Harder for communications to solve, but quite widespread issues of limited capacity, people who live in such crowded conditions that telling them to socially distance is slightly redundant advice. And then of course, in some cases, particularly those who are more geographically remote places, just low awareness and people who the mainstream messages haven't yet reached. So our approach across all the countries has been to define one overarching theme for each country, each region, that draws on these principles and is simple, emotional, and flexible, and which speaks to the why, speaks to that bigger motivation behind behavior change. And then to, within a campaign, have executions that have as few messages at a time as possible, ideally with just one key behavior, sometimes two in any given execution, that is connected to the theme and clearly lands the what. So one overarching theme and then potentially multiple executions within each campaign that execute that. So just quickly touch now on what that has meant in 2 of the countries. We don't have time, unfortunately, to tell you about all of them. So the first is Nigeria. So in Nigeria at the top, we decided that the why, the biggest why, was to do with misinformation and mistrust. That misinformation was undermining motivation to follow health advice and affecting uptake of all COVID behaviors. It was the one problem behind all the problems. So we got to this single-minded creative platform, which is spread the truth, not the virus. We show that the truth is our first defense against the virus, and we use trusted messengers to debunk myths and promote good behaviors. So that then led to individual executions that tackle one behavior at a time, as we talked about. So for instance, you land the idea, the virus is real, so wear a face mask. Or it's not a white man's virus, so keep your distance. Or herbs won't protect you, so wash your hands with soap. So in each instance, debunking a myth or piece of misinformation that was out there and correcting perceptions, all wrapped up with one idea. Meanwhile, in Ghana, a different theme. So the biggest why here that we identified, and one of the reasons the why is different is because the audience is different in different places. So in Ghana, the audience was a greater focus on young people. There's a kind of complacency and selfishness that many people were ignoring health advice, didn't realize that their actions affected others as well as themselves. So here the overarching theme was play your part, where we encourage collectivist values, encouraging people to do their bit to stop the spread of COVID-19, role modeling those who adapt to the new normal. And then again, individual executions that play to that theme and land one specific behavior at a time. So play your part by avoiding going out, play your part by washing your hands with soap, play your part by wearing a face mask. So obviously these are very short form descriptions of what the executions are doing. The executions themselves are now radio scripts, TV scripts, posters, things like that. So that's it from me. It's a very quick summary of a very large body of work, but hopefully that gives you some idea of the principles for how we approach BCC and how we've applied it to behavior change communication for COVID in these countries. I'm going to pass on now to David Agumang, who's going to tell you specifically about the work in Ghana.
David, I think you're on mute.
Apologies, sincere apologies. Thank you sincerely, Andy, and thank you everyone for the opportunity. The current slide shows the scope of the Ghana COVID-19 response. We had 2 objectives. The first objective is based on the recognition that many people were getting infected in the districts along the border with Togo. And this was mainly attributed to the movement of people across the border using unapproved routes. So we saw the need to train health workers and teachers in these areas so that they will be able to protect themselves and people in these districts. The second objective looks at our contribution towards the behavior change communication against COVID-19, which Andy has just presented to you. In all, we targeted 1,000 health workers, 200 of them in the schools. These are health education officers, and then 800 of them in the health facilities. Apologies, that number there is supposed to be 800. The cadre of participants trained include community health nurses, physician assistants, district director of health services, midwives, enrolled nurses, laboratory technicians, public health nurses, port health officers, disease control officers, and health promotion officers. The training covered mainly integrated disease surveillance and response, risk communication, and infection prevention and control. Next slide, please. So what have we achieved so far? So far, we have trained, apologies, I need to update some figures here. We've actually trained 750, as was presented to you earlier, 750 health workers and 200 teachers. But we did more than just training. We actually also created relationship with these departments and organizations. And we hope that this relationship will go a long way even beyond COVID-19 and will help NTD activities as we move forward. Also, because all these departments were trained to do case detection, we believe that that will contribute to surveillance in general, because as they detect the cases and communicate among themselves, as we've created that coordination, is going to contribute to surveillance along the border. We have learned from these activities that there are new opportunities beyond what, new opportunities for partnership beyond what we have at the moment. So the NTD program can look beyond the current partnership and strengthen new partnerships within Ghana Health Service and even outside of the Ghana Health Service. We've also learned new ways of doing remote monitoring using WhatsApp platforms, for example, and using agents, local agents at the places where we worked. We've also learned that the NTD systems can actually be adapted to support activities like COVID-19 and of course other public health, similar public health activities in the places where we work. And this is something we can look at as we move forward with NTD activities. There were some challenges. Getting the new partnership wasn't easy because most of the communication was made online. So forming this new partnership with organizations like the Ghana Education Service, with the environmental health, the port health was quite difficult. Remote monitoring requires that we identify ways of continually communicating with the people in the districts, and this was also a challenge. We needed to protect people against COVID-19, so this involved risk communication, risk assessment, I beg your pardon, to really understand the issues and providing mitigation and providing PPEs for people who are going to the field. So this is what, in brief, I have for you for the Ghana response. And we'll continue from here with a presentation from Nigeria, which will be done by my colleague, Dr. Joy Shaibu. Thank you.
Thank you, David. And while we're waiting for Joy to get online, just a reminder, if you have questions, just type them in the online chat box and we'll have some time between the breakout rooms and at the end to discuss. Over to you, Joy.
Hello.
Hi, Joy. Are
Hello?
you ready? It's your turn.
We can hear you, Joy.
Hello? Oh, yeah, so thank you, David. Can you hear me now?
Yes, Joy.
So I will run through the Nigerian COVID-19 response. Like you have heard re-echoed by most of the presenters, this has been like a marathon for us that we've had to run in a short while. For Nigeria, there were a couple of things that we planned, and that involved procurement of consumables, planning meeting at country level. We had several coordination and planning meetings. We had to also work with M&C Saatchi to develop the behavior change communication messages, not only in English, but also in Hausa, and several formats, including jingles, posters, pamphlets, billboards, TV, and social media messaging. And of course, printing of the behavior change communication materials in English and other languages was part of what we had planned to do. And all of this was supposed to culminate in the promotion of key messaging on social and digital media, and of course, using the existing health system structures, which involved training of the health workers at the state level, and also the training of CDDs. The intention is to have the CDDs and town announcers disseminate this behavior change promotion messages in the various communities as a way of empowering them to be on the driver's seat as regards to this response. And with that was also identifying and engaging influential leaders from the community, religious leaders, to serve as ambassadors or champions to disseminate COVID-19 preventive messages. And with all of this was our plan to monitor the interventions by the state and LGA teams as well. Next slide, please. So how have we fared so far? We've had to do contract amendments. Remember that the intention was to do NTD program delivery, but we've had to flex our funds and also flex our implementation in the direction of COVID-19 response. So we did contract amendments for the 3 project states in Nigeria that are involved with the implementation of this project. We identified 4 influencers in the 3 states where we're working: Kaduna, Kano, and Sokoto states. We had several planning meetings, not only with the state Ministry of Health partners, but also with M&C Saatchi, as well as our downstream partners. And when I talk about meetings, we had lots and lots of meetings. We also had to ensure that we received funds for this implementation and also to disburse the funds for the project accordingly. We had several coordination meetings. If you listened closely to the video that we played at the beginning of this session, you will hear that there were lots of collaborations and consultations. So we had several and tons of meetings to make sure that all the players were on the same page and were actually meeting the needs of the people that we were hoping to meet. We had follow-up meetings with the state communication pillar committee. These are people that ordinarily we do not work with in our NTD programs, but these are people that we had to develop relationships with. And we hope that these relationships will continue as we seek to resume NTD activities. And we have been able to finalize the English language leaflets and posters, and they are now ready for printing. And delighting to also note that the billboards for English in English language have also been activated and are already in the states where we're working. We have procured all the consumables required for all the states, and these have been delivered to all 3 states. Next slide, please. So what are our major takeaways and learnings? First, by engaging with the relevant committees, our visibility and acceptability of our NTD supported projects increased, because there are several people who are also working in similar spaces with us in the state who did not really know about what we're doing. But because we had to develop relationships with them, they are now much more aware of what we do on the NTD programs, and that has increased acceptability of our programs. Early planning meetings are also useful in helping provide direction for the project. This was one of the things that helped us because we engaged with all the partners in good time before the implementation of the project. We also learned that it's important to align our activities with the current needs of the people. This is where M&C Saatchi had given a lot of emphasis on. If you notice, the emphasis for the creation of the messages is different from Nigeria if you compare that of Ghana. So it was important to understand what the needs of the Nigerian people were, especially in the communities where we work. And of course, for us to be able to manage this kind of huge collaboration, we had to communicate effectively and efficiently. This was key also in the success on delivery of this project. We understand also that there's a tendency to focus on the majority of the community and leave important components of the communities behind. So we brought on our social inclusion team to our meetings to provide technical support in terms of the messaging to ensure that they were accessible to persons living with disabilities. And in the process of developing the creative messaging, we maintained a participatory process, ensuring that all the stakeholders were heard and that their views were also taken into consideration when these messages were developed. Thank you very much for your time and attention. I hope that you have gotten something useful. We'll continue the discussions in the breakout sessions. Thank you.
Thanks, Joy. And thank you for David and Becks and Andy as well. That was a lot of information in 47 minutes, so that's great. So right now, what we're going to do is divide this large group of people into 4 breakout sessions, and we will be sent to a breakout room randomly. And the 4 groups are behavior change, which will be led by Andy, project monitoring, and me, led by David, collaboration, which has sort of been a concurrent theme, and then broader health messaging, led by Heather. So after that, we're going to have exactly 23 minutes of breakout time, and we'll come back at 10 past the hour. So thank you very much. And again, just a reminder, please turn your videos on in the breakout sessions. I think that will make it a lot more interactive for everybody. And enjoy the sessions, and come back at 10 past the hour. Thanks. Roz, go ahead and send people away.
All right. Hi, everyone. I think
leader lists at one point, but I'm sure Joy made up for the lost time, and I hope everyone had a fruitful discussion. So in the last 15 plus minutes, we just wanted to take maybe 2 minutes for each group facilitator to report back on their conversations, and then cover off some of the questions that I know Becks has been collating from the chat. So if it's okay, Joy, perhaps can I start with you to report back on your group's conversation?
Okay, thank you, Leah. We actually had requested someone from the group to feedback. So Uwem will feedback on the major takeaways for the group. So it's over to you, Uwem.
Unmute. Okay, can everybody hear me?
Yes, I can hear you. Go ahead.
Okay, for the group 3, we started by looking at what was brought into in order to look at how the NTD were able to leverage on other related or non-related departments. And we got a lot of responses. For example, from the Pata Center, we got responses that they have to refocus and to develop NTD program going forward in the context of COVID-19. And also responses from Sightsavers that they need to broaden their relationship even within the organization by also bringing other related departments such as communication to assist in their NTD work. And then we realized that, well, even though we are bringing in new partner, we also have to face with some of the challenges in trying to orientate this new partner about NTD and how to build up such relationship. And one of the things that we come up to that is that we must first of all get the right partner that has the power to make changes. It's very important that whatever partners that we are bringing into the NTD must be able to has the power and to make the required changes. Then it's also important that we should align the NTD project to the need of the people, even in the context of COVID-19. And we also agree that it was important that there should be research which should be used in implementing any advocacy that is necessary, and we need to talk to the right people. And finally, it was important that because in most of these countries, there are task forces that have been set up for COVID-19, and it's important that the NTD program leverage in working with these task forces because they'll be there for a long time. Thank you.
Thank you for the feedback. That's all from our group, Leah.
Great, thank you so much, Joy, and members from Group 3. Just in the interest of time, we're going to move on to Heather in Group 4.
Hi, thank you. All right, so we're thinking about health-seeking behaviours in kind of a world of COVID and how we might need to integrate broader health messaging into NTDs. So we had a discussion that started about the perceived barriers of people accessing health services between things like lack of access, fear of getting COVID, mistrust or lack of confidence in existing health services based on the COVID response. And also people reprioritizing what they might use a health service for. So something they would have previously gone to seek treatment for, they might not think is important anymore. Then we had to think about potential solutions, and they were broadly broken into kind of two categories. So one very much on communications, so being very kind of clear and transparent, making sure that public health workers kind of have positive stories kind of about them and publicly rewarding them as well. And then the other side of things was looking more kind of operationally about how we can link COVID work with existing programs, not just NTDs, and also potentially set up auxiliary treatment centres as well. So there's less movement of people accessing health services and also fewer people at each of those services. And then we finished by thinking of some kind of challenges and also some ways forward. So obviously a big challenge is limited resources, but there was a point that with COVID comes new kind of cross-sectoral funding that we can potentially access, albeit very kind of complicated. Another challenge was kind of the speed of the change and the response. But on the ways forward, there's a point that we shouldn't forget the lessons that we've learned in having to respond so quickly on COVID, and we should keep those in mind. And then also a thought about if we are doing communications, we need unified messaging, not just from NTD programs, but across health more broadly. And we thought that it's been really useful to have built a lot of these cross-sector partnerships, and we've established these with the COVID work and to continue them with NTD work. So that's some of our thoughts. Thanks.
Great, thanks so much, Heather. David, are you going to report back from your group, or is there another person you would like to speak?
Yes. Thank you very much. So my group was looking at monitoring in the midst of COVID-19, especially as activities are starting. How are we going to make sure that monitoring goes on smoothly? So first and foremost, we were all able to agree that the COVID certainly is going to create issues for us as we start NTD project activities. And we agree that some of the areas that are likely to be impacted most include staff safety and the cost of monitoring. These were the two key areas that we expect to have big challenges. But in addition to this, we also have staff workload in the sense that as people continue to do COVID-19 response activities together with the normal NTD activities, there's certainly going to be a greater workload. And we also realize that face-to-face monitoring activities is going to reduce because of COVID, and therefore there will be a need to adapt to find a way of dealing with that. Another area that also came up is staff availability. As because of COVID, some of the staff might have moved to other areas. So we discussed ways of trying to mitigate some of these challenges that are likely to come as a result of COVID, this impact that we are likely to experience on our monitoring activities. So for staff safety in particular, the suggestion was that it would be good to use mobile phones and other electronic devices to collect data from the field instead of direct movement to the field in the midst of the COVID. There was also a suggestion that at this point there's a need to work as a team, getting different stakeholders who are involved in the project activities to work together, to overcome whatever risk that will be identified. We also spoke about the need to integrate activities so that we can overcome the competing demands that will come as a result of COVID-19. So planning together and integrating plans so that we can reduce costs and time at the same time. Finally, we also mentioned that even though COVID is going to bring a lot of some negative impact on the monitoring, but there are some aspects that can be beneficial. We know that because of COVID, there's now hand washing. People are more aware about the need to wash their hands, for example. So we can benefit from this the awareness that COVID has created and integrate that into the NTD wash messaging that we are using. So this is a summary of what we're able to discuss in our group.
Great, thanks so much, David. And then finally over to Andy and Joss to report back on their group before we wrap up and do questions and answers.
Yeah, so Joss is one of the strategists in my team. She was taking notes for our groups. She's just gonna give you guys a summary now. Joss, are you still there and ready to? You're on mute. Oh, there we go.
Sorry, yeah, I had to be allowed to unmute. Thank you. Great. So our focus was on behaviour change communications, and we had a look at an example of the type of journey we go on to identify how best to encourage behaviour change in a particular area. So to do that, we focused on one example of a behaviour change model. We looked at the COM-B model, which is something we often use to identify the different barriers to achieving a behaviour. And what the COM-B model stands for, it's a capability, so understanding a person's physical or psychological ability to perform that behaviour. And secondly, it looks at the motivations to perform that behaviour. And thirdly, it looks at the opportunities afforded to people to perform that behaviour. So things in their physical or social environment that can encourage and discourage a behaviour. So we focus specifically on open defecation within our group as something that is critical to the reduction of NTDs, but often a topic that can be quite challenging or quite difficult to talk about. And there were some really interesting points which came up across those three lenses. So in terms of capability to either use latrines or avoid open defecation, some of the key themes that came out were just the lack of awareness of latrines available. So not knowing where the nearest latrines are, which kind of prevents you having the opportunity to use them. A gap in access to latrines. So when there just aren't latrines in the area, people aren't physically capable of avoiding open defecation. And then a third kind of key theme within the capability bucket, which came out, was this thought of evaluating options. And when you're making the evaluation between open defecation and latrine use, often distance from the community makes open defecation feel like a safer choice, a nicer choice, and often it feels like the convenient option as well. So something that people default to because it's the easier option. We then had a look at the opportunity bucket. So what is people's opportunity to either use the latrine or avoid open defecation? And a few of the key themes which came out within this group is the thought that latrines are the unappealing options. So often they're quite dark, they're quite dirty, they're quite smelly, which can be really off-putting for people. Secondly, the thought of social norms and the fact that open defecation can be governed by these social norms. If you see other people in your community defecating in the open, then it kind of sets this example for others where it's normalized and where it feels okay. And then thirdly, role modeling. So this thought of actually needing to set the right example for young people and for children, otherwise they grow up with a particular habit and just kind of perform that activity without thinking about it as well. And then that final third bucket we looked at was motivation. And some of the things we discussed within this theme was the need for accountability. And actually at the moment, there's a lack of accountability to hold community members to account for defecating in the open, and to hold people accountable to the youth, to the younger generation who will have to grow up in an environment where NTD risk is high. And actually the need for community leaders to take responsibility for holding the community to account as well as the sort of trusted voices often within that community. And then on top of that, the need for accountability to go hand in hand with understanding the consequences of their actions. So shifting away from this quite individualistic mindset of, is it going to harm me or not, to a more collective mindset where actually you think about the knock-on consequences of defecating in the open on those around you, your family members and your community. So that's kind of not necessarily answering the problem, but gives a bit of a snapshot of the hypothesis that we would start to make at the beginning of a behaviour change process that allows us to think about what are the most effective levers we can use to start to encourage a behaviour like latrine use as opposed to open defecation.
Great, thanks so much, Joss. And I am cognizant that it's running up on 2:30 or half past the hour, wherever you may be. And we have gotten the okay from MYT. If people have time and are able to stay on for a few extra minutes, we can go through some of the questions. Understand if people have to drop off, and for those that do, thank you very much for joining. But for those of us who are able to stay on for a few minutes, I'm going to hand over to Becks to just walk us through some of the questions. And then if others have questions, please also feel free to raise your hand and maybe we can unmute you and you can ask them directly as well.
Hi everyone again. Yeah, we've got 3 questions in the chat and 1 comment. So I'll quickly try and go through those. I might ask David to step in on one of them. So Laura Appleby, she's wondering how governments were engaged in the development of messages for behaviour change and whether there were any learnings from this experience on their side. So Laura, as Joy stated in her presentation, there was a huge amount of meetings between ministries, and there continue to be. Their direction and their engagement was critical and continues to be critical in the development of the BCC materials. I don't think we can exaggerate just how many meetings there actually have been between ministries, and they have been at every stage of the process development, and things just can only move forward once there's ministry sign-off. So yeah, full engagement and direction from ministries. So a lot to be learned from there. And like I said in my presentation, we sort of expanded beyond our normal NTD program contacts, and we're able to make contact with a lot more departments within ministries. So I hope that answers your question, Laura. And then Simon Bush said, I'm interested to know how technology has been used in the responses you've outlined, e.g. in the training and retraining of CDDs. Have approaches had to change, or was it using existing tools? So David, I wonder if I can call on you to answer this question, please, given your experience.
So thank you very much. So for the training in Ghana, I think regarding technology, I can only talk of the use of the WhatsApp platform, which we used to do the monitoring of the activities. So the teams on the field were actually put on one platform on WhatsApp, so that constantly we can discuss how things are going on the field. And besides in addition to the WhatsApp, all other things are actually even though they are innovative, but they are not technology in nature. For example, we devise tools that were used for registration. This to make sure that we were, even though we're not on the ground, we're able to capture everyone, and his contact. We made sure we developed a checklist that was used to do monitoring, so that people who were doing the monitoring knew exactly what they were supposed to do. And then we also, even before the training, developed reporting tools, so that it will guide those who are doing the activities to really know what to look for, or how, what is expected of them even before they start their activity. So in terms of technology, I think it's just the WhatsApp, but notwithstanding, we were quite innovative. Thank you.
Thank you, David. And so there was another question from, and sorry for the pronunciation, Uwemendimo Ekpo. And the question was, were NTD communities involved in designing BCC COVID-19 related messages? If yes, how and what were the lessons learned? So I can answer that in part. Due to it being an emergency response, it wasn't our normal ways of working. We had to respond quickly. Like I said, in response to a previous question, we did have and continue to have full engagement with ministries in order to get their buy-in. But also we did conduct focus group discussions in Benin, and that helped inform some of the messaging, the subsequent messaging. And also we're doing pre-testing in Liberia and Sierra Leone for some of their materials. So I hope that answers your question. And then there was one final comment rather than a question, I think, and that was from Walid Rabbani, and they said, I think if we adopt telecalling as a mode of monitoring, this way we can reduce the risk of COVID-19 transmission and can result in the reduction in costs. So that was a comment made by Walid. Thank you very much. And that, as far as I could work out, was all the questions that we had. So thank you very much for all your contributions. I'll hand over back to Leah now.
Great, thanks so much, Becks. I think, I don't know if people have the ability to raise their hands or come off mute. Are there any final questions before we conclude? Oh, I see someone has raised their hand. Please come off mute if you're able to. Dr. Monjo? Are you able? Let me see if I can unmute you. Okay. Hello. Are you? Oh.
Yes. Okay.
Yes, we can hear you.
Hello, everybody. It's just a comment. In my country, for Gabon, there is a benefit effect thanks to COVID. It was a development of a PCR laboratory network for diagnostic of SARS-CoV-2, and it should beneficiate also to the diagnostic of rabies and biliary ulcer. One, because of infrastructures and the many biologists and technical workers have been trained, and also we develop procedures for transporting the samples. Thanks.
Great, thank you so much. It's really interesting. I mean, we presented one example from the work of Ascend, but we know everyone has been working hard, and I think coming forward and moving ahead, it's about how we capture what we've learned and how we move ahead as we get back into our NTD programs. And as Yalvi mentioned this morning, there's now a ad hoc COVID task group through the NNN. So I encourage anyone that is interested in joining or has anything to share to get in touch with Simon Bush or Angela Weaver, who are the chairs of those of that group. So I think there's a lot of rich information to have from the NNN, and we should make sure we're all learning from that as we go ahead. If there's no other comments or questions, I appreciate everyone for staying a few minutes over, and thank you again to Becks and Andy, David, Joy, Heather, Jordy, and all of the presenters who presented back on the group work. It was really great to hear about all the experience, and I hope everyone has a good rest of the NNN and a good rest of their day or evening, morning, wherever they may be. So thanks again for everyone for joining, and hopefully see some of you all tomorrow.
Thank you.
Thanks, everyone.
Bye.
Bye.